When we talk about thyroid nodules, what we're really talking about is the question, is this cancer or not? And it will be up to you to decide the risk based on the patient, the nodule, and the ultrasound findings in order to decide, do I need to biopsy this? So the goal will be to not biopsy if you don't have to, but knowing ultimately that the way you get the answer is by doing a fine needle aspiration. So let's talk first about risk factors. Your pretest probability for this is malignancy. That is, what is your threshold to do the biopsy? And then the diagnostic workup that you should look at in order to figure out how to get the test question right. And we'll finish off with some of the cancers or some snippets you need to know. All right, so risk factors are going to come in a couple of forms. One is going to be the patient themselves, their personal exposure and risk. One is going to be the physical exam finding. And then the other is going to be the ultrasound finding. And we'll talk about when to get the ultrasound in a minute. So the patients who have highest risk of their nodule being cancer are those who have received radiation. Radiation to the head and neck. These are going to be your Hodgkin lymphoma survivors. People who lived through another cancer, got radiation therapy, and now they develop thyroid cancer. Of course, a personal history of cancer or a family history of thyroid cancer. If they have another nodule, yeah, okay, that's high risk. But then if they've got a nodule and hoarseness, and hoarseness is there because most thyroid nodules don't really invade local tissue. So if you have a nodule and hoarseness, it means it's either going into a nerve or into the trachea and larynx itself, but that's a bad sign. And then age. If you have a thyroid nodule and you're very young, that's weird. And if you're very old, less than 20, greater than 60. But the biggest risk factor by far is radiation to the head and neck. Now, like most malignancies, if you find a fixed, firm, hard nodule, especially if there's non-tender lymphadenopathy nearby, that's very likely to be malignancy. Most thyroid nodules don't hurt, so the presence or absence of pain really doesn't help, but a painful nodule is very unlikely to be malignancy. So I'm not putting it up there, but fixed, firm, hard nodule with non-tender lymphadenopathy around it, you're in trouble. And then if you end up getting the ultrasound, what you're looking for to increase the risk is a solid mass that is hypoechogenic. That is, it's a different consistency than the rest of the thyroid. A size greater than 2 centimeters. Now, I'm putting 2 centimeters because if it's greater than 2 centimeters, no matter what the other findings are, you're going to do a biopsy. But you'll see it's 1 centimeter for most lesions. But if you see size greater than 2 centimeters, biopsy. Also on here is microcalcifications and irregular borders. So as you approach vignettes like this, if you have multiple elements, they're pushing you to get the biopsy. If you have multiple elements absent, they're asking you, hey, what do you need to do in order to avoid doing a biopsy in this patient? And so what can you do? Well, if you find a nodule, the first thing you want to do is check for a TSH. Because the risk of malignancy and a hyperfunctioning nodule is so low that this is the first place you go to decide if it's hyperfunctioning, I may not need to biopsy. So if it's hyperfunctioning, that is, there's hyperthyroidism, feedback loop will turn off TSH. So a low TSH is indicative of a low-risk nodule. But you need to make sure that that nodule is the thing making the T4. Just because the TSH is down doesn't mean the nodule is hypersecreting. So in order to figure that out, you do a RAYU scan. And if you were right, that nodule will light up. It'll be a hot nodule. This is a hyperfunctioning nodule. The risk of malignancy is super low that you do not need to do a biopsy, but instead you'll treat the hyperthyroidism. We just talked about that in the last lecture. You can use radioactive iodine ablation, surgery, or medications, depending on what that nodule ends up being. But if the Ryu scan comes back cold, it was hyperfunctioning, but it's not that nodule that's hyperfunctioning. That's a non-functioning nodule, and that's now risk for cancer. So you're going to do an ultrasound, which will help you further stratify. But if you're at this point, you're going for the FNA. You're getting the biopsy because you want to know what's in there. On the other hand, if your TSH was normal or elevated, there's no utility to the Ryu. This is a high-risk nodule, and doing the Ryu is basically useless. You know it's not hyperfunctioning, so you won't get a hot nodule on the Ryu. You don't even bother. What you do here is you get the ultrasound. And it's going to be based on risk and size. If you have a lot of risk factors, you might go smaller with the biopsy. The number I want you to remember for ultrasound finding leading to biopsy is if the ultrasound shows a nodule that's greater than 1 centimeter, this is super high risk, it's big, and you want to do the FNA. If the ultrasound shows less than 1 centimeter, this is a small nodule that you can watch and wait. So you'll repeat the ultrasound in 6 to 12 months. And if it's growing or it's bigger, then you go to FNA. But I want you to feel this. If it's solid and hypoechogenic, 1 centimeter. If it's cystic and looks like the rest of the thyroid, you might not biopsy it until it gets to 2 centimeters. But if the person has radiation of the head and neck, it's fixed firm hard, but it ends up being really tiny, you may still do a biopsy. What I want you to remember is 1 centimeter. If on the ultrasound, 1 centimeter biopsy. Less than 1 centimeter, repeat ultrasound. Knowing that, they could throw some wild cards in, giving you a robust patient history, which might push you to the FNA faster. And then, based on the FNA finding, you will take an action. If the FNA shows cancer, well, you're going to cut it out. Deciding hemithyroidectomy, thyroidectomy, not your level, cut it out. If it shows definitely not cancer, well, that's good. You're going to follow with ultrasound, 6 to 12 months. If it starts to grow or it gets bigger again, you're going to rebiopsy. But if it stays stable for quite some time, you might push out the screening to years. If you're not sure what the FNA shows, you should immediately repeat the FNA. Right? You do not let someone sit there with an inconclusive biopsy. You're going to keep biopsying until you get cancer or not cancer. And after a couple of times, you may just remove the thing with surgery to get the biopsy. The reason why we're doing this is because we want to make sure they don't have cancer. The cancers you have to know about, and there are 4 of them, are papillary, follicular, medullary, and anaplastic. Papillary cancer is by far the most common. About 85% of all thyroid cancers are papillary. The thing you should know for the test is they might give you a biopsy which shows orphan nuclei. The treatment for papillary cancer is resection. If you have to have thyroid cancer, the one you want to have is follicular. Follicular is really hard to diagnose because it looks just like real thyroid. They've got a cancer, but the biopsy says, hey, that's just some normal thyroid. That's probably follicular cancer. And follicular cancer spreads hematogenously. You might have floridly metastatic disease, but it's just like thyroid tissue. So if you gave radioactive iodine ablation, yeah, you murder the thyroid, but you also get all of the cancer. So it's like systemic chemotherapy because it goes wherever the cancer is and kills the cancer. That's why it's the one you want to have if you have to have thyroid cancer, because you simply ablate it and you're done. Medullary cancer is going to be associated with C cells and calcitonin. Calcitone down, hypocalcemia. Where the test is going to go is going to say, this guy's got medullary thyroid cancer. What else could he have? Medullary thyroid cancer is going to be part of the MEN2A or 2B syndromes. Check out MEN at the very last lecture in endocrine. What you want to know is that it's associated with the RET oncogene and pheochromocytoma. And anaplastic is the one you don't want to have. It happens in the elderly, and it is locally invasive and very rapidly fatal. It literally chokes out the trachea and the esophagus. It grows out and around the neck and grows into everything. This one kills people quickly. Okay, so what we talked about was assessing risk of patient and ultrasound, which will help you push you to a biopsy. We talked about the diagnostic tree, which involves a TSH and a RAIU if it looks like it's hyperfunctioning, that is the TSH is low, and an ultrasound if it's not hyperfunctioning, the TSH is normal or elevated. Ultimately, what you're going to do is either ultrasound or biopsy. If small and low risk, repeat the ultrasound. If at any point you're not sure, you just do the biopsy. The biopsy will tell you cancer, not cancer, or I don't know. I don't know means rebiopsy. And then you have to know a little bit about papillary, follicular, medullary, and anaplastic cancer, just the highlights enough to recognize the one buzzword to get the question right. That's thyroid nodules and cancer.